Hello everyone, my name is Mazhar Shapoo and I'm a PGY2 internal medicine resident at Detroit Medical Center, Wayne State University. Today, I'm excited to present our quality improvement project titled as Identifying Screening Deficits for Metabolic Dysfunction Associated Steatotic Liver Disease, also known as Masld, at an academic endocrinology clinic. This project was conducted by our team from Department of Gastroenterology at Detroit Medical Center, Wayne State University. Metabolic dysfunction associated steatotic liver disease, or Masld, is becoming increasingly common, and diabetes is one of the major risk factors. The American Diabetes Association has introduced screening guidelines for Masld in diabetic patients using tools like fibrosis or FIB-4 score. Screening for Masld in this population is essential for improving the patient outcomes. The main goal of our study was to identify the deficits in Masld screening within our academic endocrinology clinic. We also wanted to analyze the various factors that could affect the FIB-4 scores, including demographic data, BMI, type of diabetes, and treatment regimens. This was a quality improvement project conducted at a tertiary care center in Detroit, Michigan. We included a random sample of 200 diabetic patients from Wayne Health Endocrinology Clinic who had their liver enzymes and complete blood counts recorded within the past year. A FIB score was calculated for each patient to determine the risk of greater fibrosis, or F2, which is defined by a FIB score greater than 1.3. We collected data on age, race, BMI, hemoglobin A1C, insulin use, GLP-1 agonist use, and any liver imaging performed. This helped us to understand the patient characteristics and identify the gaps in screening. We analyzed the data from 200 patients. Demographic information of the patients involved in this study can be found in the table 1, and the summary of our analysis can be found in the table 2 in the next 2 slides. This slide represents key patient characteristics from our study. We analyzed a sample of 200 diabetic patients, and here is the summary of the most relevant findings. As you can see in this table, the average age of the patients was about 57 years. In terms of race, the majority were African Americans, about 82%, with smaller proportions of Caucasians, Asians, Arab, and Hispanic patients. Around 55.5% of the cohort had a BMI of greater than 30, indicating obesity. The vast majority, about 90%, had type 2 diabetes, while 10% had type 1 diabetes. 69% of the patients were on insulin therapy, while 46% were on GLP-1 agonist. About 46% had a HbA1c level greater than 7%, indicating poor glycemic control. Along with this, we involved other information regarding chronic alcohol use, tobacco, AST/ALT. Interestingly, the average FIB score across this cohort was 1.15. However, among the patients with greater fibrosis, or F2, the average score was significantly higher at 1.9. Now let's move on to the table 2. This slide, it shows a more detailed breakdown of the FIB-4 scores based on the BMI, type of diabetes, and GLP-1 agonist use. For BMI, patients with the BMI under 30 had a higher average FIB score of 1.28 compared to those with a BMI over 30, around 1.06. This was statistically significant with a p-value of 0.017, suggesting that higher BMI may be somewhat protective against the elevated FIB-4 scores, possibly due to the dilutional effect of the increased body mass on liver enzyme levels. Now, diabetes type. Type 2 diabetes had significantly higher FIB scores of 1.2 than type 1 diabetes, 0.75, with a p-value of 0.004. This reflects the closer link between the type 2 diabetes and metabolic dysfunction. Third, GLP-1 agonist use. Patients who were on GLP-1 agonist had a lower FIB scores of 1.04 compared to those not on GLP-1 agonist of 1.26 with a p-value of 0.012. This suggests a potential protective effect likely due to the weight loss and improved insulin sensitivity. So, the key takeaway is that the type 2 diabetes and lower BMI are linked to higher FIB4 scores, while GLP-1 agonists appear to have a protective effect. Our findings revealed a significant deficit in Masld screening among our diabetic patients. Despite the known association between diabetes and Masld, very few patients with elevated FIB4 scores underwent the FibroScan imaging. Additionally, GLP-1 agonist use was linked to lower FIB4 scores, likely due to its weight loss benefits. Type 2 diabetes showed higher FIB4 scores compared to the type 1 diabetes, consistent with the metabolic nature of type 2 diabetes. So, in conclusion, our study highlights a significant gap in Masld screening among our diabetic patients. The low rate of the FibroScan imaging, despite the elevated FIB4 score, reflects a better need for better provider awareness and structured screening protocols. GLP-1 agonists were associated with lower FIB4 scores, suggesting a potential protective effect. So what can we do to address these gaps? So we need to implement two key interventions. First, automated order sets for liver enzyme and CBC testing in our diabetic patients to streamline the screening process. Second, to educate our physicians on Masld screening protocols to improve the awareness and adherence to guidelines. Both of these steps could help to bridge the screening gap and ultimately improve the patient outcomes. At the end, I would like to thank my colleagues Ahila, Manivannan, Malek, Shatila, Varun, Nandamudi, Victor, Osio, Ranim, Chamseddin for their hard work on their project. A special thank to Dr. Mohamad Bashar for his invaluable mentorship and guidance. Finally, thank you to the Detroit Medical Center and Quest for giving us the opportunity to present this quality improvement project.